ಹಲೋ ಹಲೋ ಹಾಂ ಓಕೆ ಅದನ್ನು ರೀಶೆಡ್ಯೂಲ್ ಮಾಡ್ತೀರಾ? ಹಲೋ ಮಾಡ್ತಿದ್ದೀರಮ್ಮ? Okay. I'm sorry what happened. I just really don't know. I'll go ahead with the presentation. Okay. Okay. Now I was talking to you regarding these abnormal activities. Okay. So now I was talking to you about the hypoactive state, that is uterine inertia, cervical dystocia. Hyperactive incoordinated uterus can cause again the three different types of presentations. It can cause a constriction ring, or there can be a colicky uterus, or there can be a hyperactive lower uterine segment. So what is the etiology for this incoordinate action? So it is most commonly present in primigravida with advancing age of the mother. So in case of prolonged pregnancy is the one where the pregnancy has crossed 40 weeks of gestation. In case of over-distended uterus, as in case of twins or polyhydramnios, if at all there is any psychological factor also, there can be some amount of activity, that is incoordinated action can happen. Then the basic cause, whenever there is some pathology in the passage, that is whenever there is a contracted pelvis also, you can expect this type of incoordinate uterine action. Whenever there is a malpresentation, that is it is the fetus is, there is some amount of cephalopelvic disproportion, or there is some amount of, there is malpresentation means there can be a face presentation, bro presentation. Okay, all these things more than presentation, they are called as malpositions. Okay, malpresentations will be your transverse lie or breech presentation. In such conditions also, you can expect this type of an incoordinated uterine actions. So what will happen in this? Because of the ill fitting of the presenting part into the lower uterine segment, there is inhibition of the local reflex, which is needed for the effective uterine contraction in the upper segment. As a result of this, you land up in an abnormal activity. Okay. So next, what is the other thing? What are the other etiologies that can cause? Whenever there is a full bladder or a loaded rectum, that can also inhibit the uterine contraction. And whenever there is a injudicious administration of the sedatives like morphine, pethidine and all those things, that also can cause the uterine actions to be incoordinate. So most common incoordinate uterine action when sedatives are used will be a hypoactive uterus. And whenever oxytocics are also used inadvertently, you can have the other, that is the uterus can go in for tetany. There can be an incoordinated uterine action. Hypertonia, tetany are all more common when oxytocics are used. And whenever you are going to attempt, premature attempt at doing a vaginal delivery, then what happens? The lower uterine segment starts to act in a very different way, and it causes the constriction ring, or you can have other obstructed labor problems can happen when the premature attempt is done. So these are the things when you do the premature attempt to do the vaginal delivery, the uterine bladder, the fundus of the uterus will act in a very incoordinated way. The uterus can go in for hypertony, or it can go in for tetany, and results in the rupture of the uterus. As a result of that, we should be very careful whenever we are trying for a vaginal delivery. We should have a very careful eye on the uterine contraction. So next, coming to the next slide. So coming to let me explain to you about the each thing. Uterine inertia or hypotonia of the uterus. So what happens here is there is a weak, infrequent, inefficient uterine contraction. Okay, the intensity gradually diminishes or the duration of the contraction can be very short. The lady will have hardly in 10 minutes, she will have one contraction followed by a period of relaxation. So when you check for the uterine pressure, it hardly raises above 25 millimeters of Hg. Okay, so and when you do the clinical examination, the cervix will hardly be dilated and presenting part would not have descended down at all. Okay, so what is the etiology for this? So in this is the most commonest one is elderly priming gravida. This is one of the commonest etiological factor. Anemia, if whenever there is anemia, there can be some amount of hypoxia in the uterine muscles. As a result of this, prolonged hypotonic contractions are there and certain other chronic illnesses. So chronic illnesses again will be a predisposing factor for anemia. Okay, then hypertensive state in the pregnancy, over distension of the uterus, malpresentation, full bladder, all these things will be the cause for your hypotonia. So again your hypotonia is of two types. Primary inertia where weak uterine contractions are present from the beginning itself. Then will be the secondary. Secondary is initially the, as I've already explained to you. The lady will be getting good adequate uterine contraction, dilatation, everything was in progress adequately. Suddenly the uterus stops contracting. Okay, suddenly the uterus stops contracting and uterus will go into a state of inertia. When can you expect this? This is again one of the nature's protective mechanism where it is highlighting, it is giving you the thing, it will giving you a cleansing point. See, the lady must be having some abnormality. There may be some malposition. So it will prevent the lady from going in for obstructed labor. Then you are going to again reassess the lady and see whether there is any malposition that is there, and accordingly the decision to whether to continue the normal vaginal delivery or whether you are going to intervene there and take up for the cesarean section can be taken. So these are the two types. That is primary inertia where there is a weak uterine contraction from the beginning. And next is a secondary inertia where the lady was having an adequate contraction, suddenly it has stopped. So what are the causes for the secondary inertia? It can be because of the malposition or it can be because of the exhaustion, dehydration of the lady. The lady can go in for secondary inertia. Okay. So next, what are the signs and symptoms of this inertia? So patient feels less pain, discomfort during uterine contraction. When the hand is placed over the uterus during uterine contraction, not only reveals hardening of the uterus before patient feels pain, but contraction outlasts the pain. And when you do when the uterine wall is easily indentable. I have already told you when the uterus is having adequate contraction and you indent over the fundal region, your finger will not indent the abdominal wall. Whereas in this case, you can easily indent. And when you examine, there is no dilatation and there is no descent of the fetal presenting part. Okay, so diagnosis is again by doing the internal examination. Then you are going to see whether there is any malposition, is there any deflexed or any malpresentation which might have been missed. So what are the complications because of this uterine inertia? So because of the uterine inertia, effects on the mother. You can have a prolonged labor, maternal distress, dehydration and psychological depression can be there. There is increased risk of infection because you have left the lady for a prolonged period to go in labor, and because of this there is increased risk of PPH. So why there is increased risk of PPH? Already you know the uterus is gone in for a state of inertia. It is not at all contracting. As a result of this, this lady is more prone for postpartum hemorrhage. You are going to expect this whenever the lady is having an inadequate uterine contraction during the labor, you should always keep in mind this is one of the high risk factors for postpartum hemorrhage. Then is the subinvolution. What is subinvolution? After the delivery, usually uterus goes back to its normal position within a period of 6 weeks. Okay, so within the period of 6 weeks, the uterus becomes the pelvic organ, and normally we expect that immediately after the delivery, your uterus will be at the level of the umbilicus, and every day it will reduce by 1 centimeter in size. Subinvolution means this reduction in the height of the uterus following delivery will not happen. This is also because of the abnormality in the contraction and retraction. Okay, so this is again one of the late complication of your hypotonic uterus. Okay, so next coming to the fetal complication. Fetal distress is more common because of the rupture, and fetal septicemia is expected because of the prolongation of the labor. How will you manage this? So careful evaluation of the case has to be done, and patient, we should make sure whether really the patient is in true labor or false labor, exclude cephalopelvic disproportion, and then accordingly the management protocol has to be done. So when it is detected in the first stage of labor, so see for if there is any contracted pelvis, you are going to take her up for a cesarean section. If at all there is no contracted pelvis, malposition, maternal distress, nothing is there, then you have to take certain general measures. That is, you have to keep up the morale of the patient, empty her bladder, and then give her adequate fluid and relax her by giving certain amount of anxiolytics, and also by giving her some amount of pethidine. You are going to reduce her anxiety, and then you are going to give her adequate oxytocin and accelerate. Acceleration of the uterine contraction can be brought about by doing a rupture of membranes. Artificial rupture of membranes can be done, and then oxytocin can also be started. It is not contraindicated. You have to be very careful. You have to monitor the uterine contraction and slowly the uterine. In our hospital, we are going to start with the 5 units of oxytocin and initially start the drip rate at around 8 to 16 drops per minute, and at a period of 30 minutes we are going to increase and see for whether the lady is getting adequate contractions. And in the meantime, we also monitor the fetal heart rate. The fetal heart rate has to be monitored, and along with that we have to check for the progress of the labor, whether the lady is progressing or not progressing has to be seen for. So this is, and if at all it is detected in the second stage of labor, if the case is seen in the second stage of labor, you have to exclude all the parameters and see for the maternal condition. If everything is fine enough, only you are going to augment the labor using the oxytocin. Otherwise, she will be a case for cesarean section if at all there is any malposition, malpresentation, or a contracted pelvis. Okay, and sometimes after the full dilatation, that is, the labor can just get arrested in the second stage of labor because of this hypotonia. Only if the head is very lower down, where you can apply the instruments like forceps or vacuum, that to the presenting part should be at the level of the +3 or +2, then only you are going to use the instruments. Otherwise, you are not going to use the instruments. Okay, in that condition you can directly take her up for a cesarean section. Okay, if at all head is not sufficiently low down, you can give stimulation and then try. If it is an intrauterine fetal demise, then the destructive procedure like craniotomy can be done. Okay, the third stage, you people should always be very careful. You should be ready with the third stage management. Okay, management of third stage has to be taken care of. What is active management of third stage of labor? Immediately after delivery of fetus, you are going to start the oxytocin. So you are going to give 10 units of oxytocin intramuscular and 10 units of oxytocin can be started as an IV infusion. Never give IV bolus of oxytocin. It is going to be of harm to the mother. Okay, you are going to either give intramuscular or you are going to give the intravenous, and then the placenta, after it is separated by controlled contraction, the placenta is removed and an adequate uterine massage is given. So this is the third stage of labor. If you are anticipating and if there is some amount of atonic postpartum hemorrhage, you should be ready with the management of the atonic postpartum hemorrhage. That is, you should keep your oxytocin, that is your 15-methyl PGF2 alpha, that is your carbaprost, misoprost, and adequate oxytocin should be ready. So methergine is a very last resort. Don't ever give methergine in the beginning. Try with your carboprost, increase the dose of oxytocin, and then try with your uterine massage, and adequate uterine tamponade has to be given to prevent the postpartum hemorrhage, because whenever there is hypotonia, postpartum hemorrhage is expected. Okay. Next, coming to your hypertonic uterine action. It is defined as either a series of single contraction lasting for 2 minutes. This is called as hypertonia. Okay, 2 minutes or more, and or there can be a 5 or more uterine contractions. Each with that will not, there will be a contraction. The uterus will not relax. Again, there will be a contraction. This is a hyperstimulated. This is called as tachysystole. So the difference between hypertonic uterus and tachysystole is, in hypertonia there will be a single contraction which lasts for more than 2 minutes, whereas in tachysystole there are 5 to 6 contractions. So what are the examples of this? So you can have a spastic lower uterine segment, you can have a colicky uterus, asymmetrical uterine contraction can be there, there can be a constriction ring, or there can be a generalized tonic contractions can be there. All these totally put together is called as an incoordinated or a hypertonic uterine contraction. Okay. So next, coming to the incoordinated uterine action. So you have a strong painful uterine contraction, high frequency, associated with low cervical dilatation. The two poles of the uterus does not function rhythmically. That is only your upper part. The fundus is contracting and contracting, whereas your lower uterine segment is not at all yielding. There is no dilatation at all. Okay, so only the upper segment is going on contracting. The lower uterine segment shows no change or no progress. Okay, so what is the clinical features? The labor is prolonged, uterine contractions are irregular and they are more painful. The pain is felt before and throughout the contraction with a marked low backache whenever there is a malposition like an occipito-posterior position if it is there. And then there is a high resting intrauterine pressure in between the uterine contractions, and there is associated slow cervical dilatation. There can be premature rupture of membranes, maternal exhaustion and fetal exhaustion is commonly expected in it. So what is the management? If you are suspecting that it is a cephalopelvic disproportion, then you are going to directly take her up for a cesarean section. If at all cephalopelvic disproportion is not there, vitals have to be monitored. That is the maternal hydration, pulse, temperature, blood pressure has to be monitored along with the uterine contractions and fetal heart rate, and the fluid therapy has to be maintained, and also the intake output chart also should be maintained. If at all the lady is going for exhaustion, there is every chance that it can also affect the urinary output. Okay, so whenever there is a continuous pressure over this thing, obstruction, the urine output also will be less. The bladder itself will be getting advanced and bladder itself will be getting filled, and that itself is a hindrance for uterine contractions. So all these things you should carefully monitor. Fetal heart rate has to be monitored every 15 minutes and the partograph has to be charted. Once the partograph is charted, you are going to see whether the labor is progressing normally. If at all it crosses the action line, alert line and the action line, then you are going to directly, without waiting for further testing, take up the intervention. See, do an AR, artificial rupture of membrane, start with oxytocin and all those things. See, if the labor doesn't progress, it is decided to take her up for a cesarean section. When there is a fetal distress, that is deceleration in the fetal heart rate is noted, she will be taken up for the cesarean section. Okay. So colicky uterus. Colicky uterus, various parts of the uterus contract independently. So this is one type. And then hyperactive lower uterine segment. So here what happens, it's only your lower uterine segment is acting, whereas the fundus is not at all supporting. What will happen in such conditions? So only your lower uterine segment, there is a dilatation, but the presenting part would not have descended down at all. Okay. So in such conditions also, you will have to take the lady for a cesarean section. So whenever there is a hyperactive lower uterine segment, in this case also, you are going to anticipate excessive blood loss. Okay. So next, coming to the constriction ring. So what is this constriction ring or a contraction ring? So it is persistent localized annular spasm of the circular muscles. It can occur at any part of the uterus, but most commonly it occurs at the junction of the lower, upper and the lower uterine segments, and it can occur at any time. It can occur at first stage, second stage and third stage of the labor. It can occur at any time of the labor. Okay. So what is the cause for this constriction ring? So malpresentations, malpositions, premature rupture of membranes, premature attempt of instrumental delivery, intrauterine manipulations under light anesthesia. That is, sometimes when we see there is some amount of fetal distress, the cervix is not at all dilating. So what we will do, we will put our fingers, try to stretch the uterus and all those things. So in such conditions, what happens? The uterine reflexes will behave in a very uncoordinated way and the upper segment contracts very badly and you can have a constriction ring forming at the lower uterine segment. And also whenever the oxytocin is not being properly monitored, and some people who don't know, that is in the outskirts or in some PHCs and all, they give 10 units of intramuscular oxytocin and all those things, which will cause this type of an uncoordinated uterine action. Okay. So next, how will you diagnose this? The condition is more common in primigravida and it is frequently preceded by a colicky uterus. Colicky uterus is the tetanic uterus where you are going to have a continuous uterine contraction without any relaxation. So in such conditions, you can anticipate that this lady can develop a constriction ring. Okay. So what are the complications because of this? Prolonged first stage of the ring occurs at the level of the internal os. So prolonged second stage, the ring occurs around the fetal neck. In the third stage, what happens? The baby would have developed, baby would have been delivered out. The placenta is stuck inside. The hourglass constriction of the internal os. Internal os gets closed and your placenta is remaining inside only. So this is how at each stage this constriction ring can affect the progress of the labor. Okay, if it happens in the first stage, your internal os will form a constriction ring and there will be no progress of the labor at all. So what happens in the second stage? It will be around the fetal neck and it causes the fetal distress. Okay, so this is how your constriction ring can behave. So what is the management? So exclude malpresentations, malpositions. In the first stage of labor, you can give pethidine, morphine only to relax the pain. But if you notice that there is a constriction ring in the first stage, she will be taken up for a cesarean section immediately because we do not want the fetus and the mother to go in for any exhaustion. And in the second stage also, general anesthesia is given so that the constriction ring gets relaxed out and the fetus, depending on what exactly is the position of the fetus in the pelvic region, it will be either delivered by using an instrument or immediately after relaxation, the lady will be taken up for a cesarean section. In the third stage, you are going to give the general anesthesia, the uterus relaxes, and the manual removal of the placenta will be done, and oxytocin adequately will have to be given. So coming to the pathological retraction or the Bandel's ring. So normally you have a physiological retraction ring. It is a line of demarcation between the upper and the lower segment present during the normal labor. It cannot be felt abdominally. So they can ask you this question: what is physiological retraction ring and what is pathological retraction ring? So physiological is a normal demarcation between the upper and the lower segment. So what is pathological retraction ring? It is raising up retraction ring during obstructed labor. You have marked retraction and thickening of the upper segment with relatively passive lower uterine segment markedly stretched and thinned out. So you find that there is the upper segment is completely contracted and you can visibly see the difference. Your lower uterine segment is very passive, you can see, and along with that there will be other features of the obstructed ring, that is you have the thickened and pulled round ligament segment, round ligament thickened and pulled. This is called as Fromel's sign. Okay, thickened and edematous round ligament associated with a retraction band, that is the upper segment is thick. You can visibly see the Bandel's ring. Okay, so that is abnormal. So the Bandel's ring is seen and felt abdominally as a transverse groove. This is the clinical picture of obstructed labor, and obstructed labor has to be immediately taken up for a cesarean section. So whenever you are having this obstructed labor, there is every chance that the bladder also will be pulled up. We should be very careful when we are delivering the lady by cesarean section in case of obstructed labor. There is every chance that we may, if we are not careful, we may injure the bladder. Okay. So how will you differentiate between a constriction ring and a retraction ring? This table is being giving you the difference between constriction ring and retraction ring. This can be a short question for you people, so you will have to note about this. Okay, anyway the slides will be shared to you people. Go through these things and you have to make a note of it. So what is the clinical feature of this Bandel's ring? Mother becomes tired, restless because of this continuous pain. Maternal distress and ketoacidosis is there. The upper segment is hard, uniform, and retraction ring is very well felt. Vagina will be very hot and foul smelling. The cervix, though it is fully dilated, the presenting part will be high up and fetal. Most of the times, if at all the obstruction is not identified at the earliest, you may lose the baby. Okay, so you have to be very careful. That is why partogram and monitoring of the fetal heart rate is very important. So provide adequate support, analgesia, hydration, prophylactic antibiotics have to be given. Nowadays destructive surgery is ruled out. Even the baby is dead, we are not going to do the destructive surgery so that we are not going to cause more of maternal morbidity. If the fetus is alive, immediately the cesarean section has to be done. So only for the benefit of knowing, you have to know about the destructive surgery, that is the craniotomy, symphysiotomy, and all these things are the destructive surgeries which in the modern day obstetrics is obsolete. Okay, coming to cervical dystocia, failure of the cervix to dilate within a reasonable time in spite of good regular uterine contraction. It can be secondary, organic, or it can be secondary due to cervical causes like if at all the lady has undergone any cone biopsy, extensive cauterization, obstetric trauma, organic lesions like cervical myoma and carcinoma, you can expect this. And primary or functional, in spite of the absence of any of these organic causes, the lady can develop this cervical dystocia. Okay. So the cervical dystocia can be because of the lack of softening of the cervix during the pregnancy, or cervical spasm resulted from overactive or excessive fibrous tissue. You can anticipate that. Okay, so what is the etiology? Ineffective uterine contraction. Again, your malpositions and malpresentations. Spasm or contraction of the cervix is the cause for the cervical dystocia. How do you manage? So whenever there is an organic dystocia, whenever there is an organic dystocia, you are going to take the lady for a cesarean section. So if at all you think that it may be because of ineffective uterine contractions or so, you are going to try to do some corrections. If it is not happening, the lady will land up with cesarean section. So generalized tonic contraction or uterine tetany. In this condition, pronounces a retraction occurs involving whole of the uterus up to the level of the internal os. Thus, there is no physiological differentiation between the active upper segment and the passive lower segment. As there is no thinning of the lower segment, there is no chance for rupture of the uterus, but uterine contraction ceases and whole of the uterus goes in for a tonic muscular spasm holding the fetus inside. So there will be a obstruction to the uterine, though the uterus is having a maximum this thing, the passenger is not at all being pushed. So whenever you see such condition, so you have to administer immediately for the benefit of the fetus some amount of tocolytics. What are the causes? Injudicious use of the oxytocics. So what is it? Whenever the misoprostol is used more than, so normal expected, WHO has told us we have to use only 25 micrograms of misoprostol, that is your PGE2. If at all more than 100, or sometimes if the lady is very hypersensitive to it, then you can anticipate this uterine tetany. The lady will have a uterus which has gone in for spasm. So, or when the oxytocics are inadvertent, that is oxytocin is not used properly the dose is not titrated, then also you are going to anticipate this problem. Okay, the patient is in prolonged labor having a severe continuous pain. The As a result of this, sometimes there can be abruption also. The fetal heart rate will be decelerating, and vaginal examination reveals it will be revealing a jammed head with a big caput. So in this you have to correct the hydration by giving fluid therapy. She will have to be taken up immediately for cesarean section. Thank you. And one more thing, in this in this class, you will have to know about for you will get 3 or 4 questions from this. One is obstructed labor can be a short question for you people. Bandel's ring can be a question. Differentiation between constriction ring and a pathological ring can be a question for you people. So in this class, you may have to prepare for these 4 things. Okay. So thank you.